Hello, welcome to the next episode of Lessons from the Lab. I'm Devon Rubin from Mayo Clinic in Jacksonville, Florida, and I'm going to be hosting this new episode in which hopefully we'll learn something about an uncommon problem and it's a little bit about neuromuscular ultrasound as well as EMG. I've been looking forward to this episode. It's been a bit difficult scheduling our guest because she is a world traveler. She's all over the world, both for pleasure and teaching. She's a world expert in neuromuscular ultrasound. And I'm going to present a case to her that she is not aware of. It's a case that was somewhat complicated, and we see sometimes in our laboratory of a patient that has some shortness of breath and we're asked to evaluate for the cause of the shortness of breath. So I hope that this is educational. I know I'm going to learn something. I hope you enjoy it, and let's get to our guest. All right, well, welcome to Lessons from the Lab. I'm Devon Rubin, and joining me today is a wonderful guest, Andrea Boon. Hi, Andrea.
Hi, how's it going, Devon?
It's going well. Dr. Boone's a professor of neurology and physical medicine and rehabilitation at Mayo Clinic in Rochester. That's where you are right now, right? You're at
Yep,
work
I'm
today.
I'm at work.
Yeah, and you're doing intraoperative monitoring right now.
Today, that's what I'm on. Yep.
Okay. Well, fortunately, I'm not going to talk, or unfortunately, about IOM today. We won't discuss that. We have something more interesting to talk about. So I'm glad to have you on this. I know it's been hard to schedule. You were in New Zealand?
Yep. Just got back from New Zealand. I try to go there every Minnesota winter because it's the summer in New Zealand, so it's a good time to get out of here. And
Yeah.
yeah, it was fun. Got to see family and get some nice weather, play a little golf with my dad,
Okay.
who's turning 90.
Nice. Did he teach you
Yeah.
anything and teach you
Well,
any tips, or do you
he
teach
g-
him?
he he gets a little upset that now I can outdrive him. I'm like, well, Dad, you are 90, and then he anybody who's a golfer will laugh because he was upset that he shot a 93, which like most
Yeah.
people would be fine with that.
Right, right. Well, I certainly would. And I would never be upset when I outdrive me, and you have done that many times. So, well, I'm glad you had a nice time and
Yeah, it
are
was
back
great.
home. Well, part of this lessons from the lab is to kind of discuss an approach to a case so we can teach the viewers, and I always like to learn something myself when I have guests on here. So I thought I would present a brief vignette and just kind of pick your brain on it and see what you would do in the lab and how you would approach this patient. So you ready?
Yeah, I would just like to preface this with that it's very hard to teach you anything, Devin. I think you know it all. So,
Well, I don't know much about what I'm going to present, so I'm going to
well,
rely on
hopefully
you.
I do. Okay.
So this was a case that we had in our lab a few months ago, and the history was kind of vague, but he was a 60-year-old man, and he had had sort of some chronic neck pain, but he had kind of a period of time over a week or two, and it was vague with increasing pain. And then after that, he developed some shortness of breath. And he basically, and he couldn't say it was it one day or was it over the course of a few days, but over about a week or two, he noticed that his breathing was more difficult. And it was particularly worse when he would lay down at night or exert himself, but laying down in particular, he was short of breath. And he had never been like that before. And so he went to his primary care physician and to evaluate this, and they did a chest x-ray, and he was known to have an elevated hemidiaphragm at that point. So he was sent to the EMG lab to kind of evaluate his respiratory function, and they were worried about his diaphragm or his phrenic nerve, and so they wanted to see if that was the problem or if he had some other problem causing a shortness of breath. So that was kind of the story. He didn't really have any other neurologic type of symptoms. It was more really the dyspnea that presented to the EMG lab. So I imagine you've seen patients like that.
Yeah, we get a lot of people referred to the outpatient EMG lab at Mayo Rochester for a lot from pulmonary in particular, but kind of rule out neuromuscular weakness as a cause of their shortness of breath. So it's a
Yeah.
pretty common presentation.
So yeah, and we see that too. And so I guess the question, if this was the patient that, came to the lab, what is your approach to this patient? What do you how do you evaluate
So
them, or what do you think?
yeah. So obviously, I think, you want to get your focus history and exam and make sure it really is just isolated respiratory dysfunction. Otherwise, you might be looking at doing a more extensive workup, ruling out things like ALS and other myopathies that could involve the diaphragm preferentially. But if it's purely the chief complaint is shortness of breath, our typical approach, we kind of have an algorithm that works well with our technicians and then the physicians doing the study together. Our technicians will go in first and do phrenic nerve conduction studies bilaterally, and then actually we'll do an initial ultrasound exam for us and take a look. I always say start with the good side. If there's one side that's supposed to be elevated, then start with the other side for the diaphragm ultrasound to kind of get a baseline. So we'll do an ultrasound of both sides of the diaphragm, and then if we need to, depending on the findings from the phrenics and the ultrasound, and also depending on the kind of clinical index of suspicion, we'll do diaphragm needle EMG, typically just on one side, but really we will do both sides.
Do you do you do you do conductions in elsewhere, like in an arm or a leg, or do you just go right where the diaphragm
It,
is?
again, it depends on the patient. Certainly, it'd be very reasonable to kind of do a little bit of a workup in, say, an upper limb. So again, it depending on what my kind of initial differential diagnosis is. So a lot of times these parsonage Turner cases that can affect the phrenic nerve preferentially. So it can be helpful to do nerve conductions, motor and sensory in an arm, along with some needle EMG. Similarly, if there's any question of myopathy, it's nice to do a few axial muscles. Yeah, well, you could do an axial muscle and then, do a couple like a deltoid and a biceps just to make sure you're not missing a myopathy.
Hmm.
So I think you have to be keeping your differential diagnosis open. But if it's purely shortness of breath, we might do the diaphragm workup. And if everything looks perfect, we might not go down that route.
Hmm.
Kind of
Okay.
depends on the individual patient, I think, and
Right.
using your clinical acumen.
Sure. Yeah. Well, can I show you actually what we did? It's
Sure.
interesting. I'm gonna share my slides here. Hopefully you can see
Yeah.
this. And you have an
Okay.
algorithm, and it's funny that you say that because we kind of do the same thing, and you might not
Right.
be surprised since we're similar, different sites, but similar institution. But this, I don't know how well you can see this, but this is what our text did, exactly what you did. They did, this is the right side over here, and this is the left phrenic.
Right.
And
So
so,
that's pretty impressive. I mean, they got obviously no response on the right side, and it looks like you use the two-channel recording, which we do. So we use two different techniques because sometimes you'll pick up a better CMAP from a different area of the chest wall. So we put G1 in two different areas. And then on the non-affected side, you've actually got a pretty good CMAP there. It looks like what's that? So
yeah,
the
it's like,
amplitude is 0.4, is it?
yeah,
0.4?
0.4 and
Yeah. So
0.5, yeah.
that's pretty good for a phrenic CMAP, I think. And I mean there is a big dip there. It makes you always have to worry about volume conduction with phrenics because you're pretty close to the brachial plexus, and so it can be easy to inadvertently stimulate the plexus, and you can get a response that looks like a real CMAP.
Mhm.
What was your stimulus? Can you see what
I
the
think we were given,
intensity
yeah, I know
was?
we both are having a hard time on this seeing, but we're getting older, and it's
Yeah, I'm
like
blind
20,
to
it was
start
like
with.
21 or
Oh,
20.
so
So it
that's
wasn't,
low stimulus.
yeah, it was
So
pretty
that's
low.
nice. I mean, they did a good job, and I'm sure, sometimes I just talk to the tech and they're like, yeah, it just popped right up on the one side. And the other
Mhm.
thing you can use to help you confirm if it's a real response is ask the patient. They should feel a hiccup if you're stimulating their phrenic nerve. So if
Yeah.
they get a nice hiccup on that side and you get a nice response, then you can be more comfortable that that's a true phrenic CMAP, even though that morphology, especially of the second response, is a little bit atypical and
Yeah.
makes you sometimes worry about volume conduction.
Do you think that you have to do both techniques? So xiphoid and then
I I like to, because you'd be surprised how many times we choose one technique one time and the other another time. I mean, it's not very consistent as to which one's going to be better. And if you get a response from both, I think that's just kind of nice as well. I don't think it hurts to do both. It's very easy. Just stick on two more electrodes. So what's the
right.
downside, you
And
know?
and I think maybe I don't know if you agree that, these are nice responses, but many times the responses are lower amplitude. We're not really sure, is that really a response or not? So,
Right, and that second one on the right side of the screen, if I just had that alone, I'd be more worried about volume conduction just because of that big dip and everything.
mhm,
The first one is a nicer, is more of a response I'd like to see. So again, that helped having them both there, I think.
yeah. So if you got this, would you still do ultrasound?
Um, so yeah, I would. The reason I would do ultrasound on the non-affected side is just to kind of see what a baseline is. I definitely do it on the affected side where we got no response. But I like to, if we're going to do one side, we usually do both. And there's a few reasons for that. One is if you start with the normal side, it kind of gives you, it's a lot easier to see a normal diaphragm on ultrasound than a very abnormal one. So you know kind of what depth you should be finding the diaphragm at on the image. And then you can look across to the affected side and try to correlate that.
Okay.
It also, a lot of these patients that have a very abnormal side, often the normal side will really be a robust ultrasound response. So, in other words, you'll see a decent thickness at rest, and then it will double or triple in thickness when the patient breathes in. And so they have a very healthy diaphragm that's kind of compensating for the other side that's not working.
Hmm.
So it's kind
Okay.
of nice to get a feel for how well the unaffected side is working.
Well, we did do it. So I'm
Look at
I'm
that.
gonna have you, don't
Perfect.
critique our technique, but it and just before I show you these, I'm gonna play these two videos and see what you think about them. You said you have your techs do this.
So our techs are really quite good at this now, and so they will do it. And most of the time, they're better at it than quite a few of our staff.
Hmm.
Some of the really hard ones, we go in and we try to figure. We'll go in and do it together as a team. But our techs and our fellows, we train our fellows to do it too. So usually it's those people doing it typically.
Yeah. Okay. Well, I'm gonna play these, and I know it's always hard when you're just looking at someone else's image or
Oh no, these
video,
are
but
good images. It should be
but
easy to see.
yeah. So I'm gonna play this. This is
The
the right
normal
side is
side,
the normal
obviously.
side. So I'm gonna
Yeah.
play this here.
So yeah, I don't know. I can't use a marker, but so there we go. There's the lung coming in there on the
Here's
right.
the lung here. So this is the diaphragm, right? Right
Well,
here.
it
Let me
should be. Yeah, although it's interesting because that lung comes in a little bit lower, a little bit deeper than I would.
here's the lung,
Yeah.
right?
Yeah, so actually, yep, that's all. That's so.
Do you think this whole thing is the
I
diaphragm? I'll
if
play it
you
again.
yeah, if you look at the very end of the lung coming in, there's almost a layer there. That layer below it is the diaphragm.
Right
That's
here,
actually a
this.
layer. No, like right below that.
Down here?
See there? Yep. And then if you watch that, that got really thick because the top of the diaphragm, see that layer
Yeah.
there. So on this
I'll
view, you don't even see it.
I'll play it again
That's
here.
intercostal, the one that looked like diaphragm. Right there, that's all diaphragm
So
to
this
the
is all
left of the lung.
diaphragm here,
Yes, yes.
and this is the intercostal
Yeah, and this is a tip that I use to identify what is the diaphragm. The top of the lung, so the most superficial aspect of the lung,
right
is going to
here.
be at the same level as the most superficial aspect of the diaphragm. And anything above that is intercostal. Because if you think about what you're seeing, when you breathe in, you're looking through the chest wall between two ribs when you look with ultrasound at the diaphragm. And first of all, there's diaphragm is the layer immediately below the intercostal. When the lung comes down and expands and comes into your field of view, the diaphragm is going deep, down into the abdomen and out of the field of view. So they're actually exactly at the same depth.
Hmm.
So it's a nice way. So this is a tricky, this is really interesting. I don't think I've ever seen one that looked just like this, but you had to watch it. The video was super helpful because
Yeah,
you
it's
only
up
see it at the end of the video. So like there. So go back just a little bit.
here. I'll stop
Yeah,
it.
play it again and then we'll stop it. I'll tell you when to stop it. So stop it there. If you
Go
if you
back
could
just a little
roll,
bit.
yeah, if you can roll back, see that layer there?
Right here.
Yep. That's your diaphragm.
Yeah. So it is tricky because if you
So
don't look, if you look at it, I'll go back. If you look at it right here,
yeah,
what you're
now
saying is people could get fooled and say this is all
yes,
diaphragm when it's
yeah, and the one
intercostal.
tip there is that the layer, the layer that of the top layer of muscle actually goes over a rib, right? It goes right
Up
across the
here,
top of a rib. Yeah, up
up
there.
here,
So that cannot be intercostal because
right?
intercostal is between ribs. So that's abdominal, that's external oblique, comes all the way up.
Hmm.
And then the
And
next
then,
layer is truly between the two ribs.
so
So
if you
that's
follow the rib
intercostal. Yep.
and
So we
down to
know that that's
here,
the top of the intercostal. And then exactly the diaphragm on this image is a little hard to see, but it's that
it-
next layer. Yep.
down here that you can't see until
Yeah.
you're
Until
saying
you see
till
it.
right here,
Yeah. And if you keep going, you actually so that's there.
there,
That's it there.
right here.
Yeah. Yep.
Huh, interesting.
And then that's actually a typical picture. You can see the kind of the white line in the middle of it. That's sort of we think
Hmm.
that's the central tendon forming. You see some fibrous tissue within the muscle, but the whole muscle is from the top white line to the bottom white line
Right
right
here.
there.
Yeah.
Yeah.
So how would you know that this is, I mean, if you saw this, you would think this is normal, right?
Yeah, absolutely. That looks like a nice normal size diaphragm. And then this is a bit of a tricky video, but there is at one point you can see that it really thickens nicely. I can't remember if it's
Maybe
like
right,
right
right
before the
in
lung comes in, it's
here.
starting to thicken and it gets even thicker right there. It goes all the way down.
Yeah. Oh,
Um,
yeah, yeah. I'll try to get back. I see what you mean. Maybe right here. Well, where's the, yeah,
yeah,
because there's the lung.
exactly.
And so as the lung's coming back, it's going
Yeah, it's
back.
as you see it back, it'll be just a split second, you know,
Yeah, I didn't
and
get the
then it's
right
starting
spot,
to
but
get, yeah,
yeah. So,
a
okay. So
tricky one.
you're looking at the thickening of that,
Yeah,
of the diaphragm, and that
we
tells you
also,
it's contracting.
yeah, you look at the baseline thickness to see if it's atrophic. If it's more than, but it can be pretty thin at baseline. So if it's more than 0.13, 0.14 centimeters, then it's normal thickness. But obviously, a lot of people it's much thicker than that. And then you look at the thickening ratio. So it should be contracted. It should be thickening, getting at least 20%
Okay.
wider, and ideally more than that.
Okay. So let me play this one. This is the
Yeah.
affected side and
Yeah,
see what
and
you think
so
about.
if you just look at the layers again, so you can see there's the rib, and so right off to the right of the rib, that first layer is going to be intercostal. Yeah, from there actually down to that.
To
Yep,
there.
and then that's
All
going to be
of
the diaphragm, that little white.
this.
That's mostly it's almost all connective tissue and hardly any muscle. It looks like to me, but we'll see on the video.
So you're
And
looking at the signal, the hyperechoic signal here compared to down here. It looks very
yeah,
different.
there's hardly any blackness in between the white peritoneum and pleural coverings of the diaphragm.
Right.
So
So
this
here I'll
one,
play it.
yeah, so there you can see a little kind of black.
And he's trying to he's taking a breath. So
Yeah, and it's not doing anything. If anything, a lot of these ones will actually thin when they try to take a deep breath in. I think the diaphragm kind of gets squashed between the lungs and the
yeah.
liver. Is this the right side or
Yes,
the left? Yeah,
this is
I
the
thought so because look, it's got that nice liver underneath it. The liver always gives a
right
nice
here.
acoustic window. Yeah.
Hmm.
Um, and so that's probably at rest, and then he's trying to breathe in, and it actually looks to me like it gets a little thinner,
Hmm.
which is
So it,
something we've kind of observed. We call it paradoxical thinning. So I think you just get these very atrophic, floppy muscles that there's no muscle tissue left, and so when they try to breathe in deeply, their liver kind of comes up because they're using all their abdominal muscles to try to breathe in, and then their lung does expand some, and I think it just kind of
kind of
squashes that
stretch.
tissue,
Right.
the diaphragm between those two, and it actually gets a little thinner, whereas
Right. Right.
it should always get thicker when you breathe in because that's when the diaphragm's active.
Okay. So this is very abnormal, right?
Yeah,
And this
yeah.
fits with what you would fit
With the absent
correlate with the neuro.
CMAP,
Yeah.
there was no CMAP, and he's clinically quite impaired, even though it's unilateral. They used to say, a lot of clinicians, you say, oh, if you've got unilateral diaphragm involvement, you don't really get very symptomatic. That's not my experience at all.
Hmm.
Especially in people who are a bit obese. You add that on, and it makes it so much more work for the diaphragm that they really notice these symptoms, even if it's unilateral.
Hmm.
And there's definitely a decent number of patients with unilateral involvement that get the orthopnea and, dyspnea or exertion and trouble bending over to tie their shoes.
Right.
Um,
Yeah.
and I don't know if I'm sure you're aware of this, Devon, but we actually published a paper to try to improve awareness. Any patient with this should be told about the risk of immersion. There's been near drowning episodes when people jump in, and just that extra pressure on the abdominal wall and on the chest wall, they really get short of breath and into trouble in the water, even with unilateral
Wow.
diaphragm involvement.
Yeah, I don't know that I'm familiar with that paper. That's been
Yeah, just
published recently?
recently in the last, I don't know, 2 to 3 years, Chris Klein was the main one, and he just felt strongly that we needed to educate, clinicians out there to warn their patients when
Right.
they do have phrenic nerve palsy, even if they don't seem very symptomatic with the routine stuff, to be very careful when they first get in water to make sure they don't get,
Right.
impaired.
Right. Wow, interesting. Well, so good. Well, that's really helpful. And so this just to show you, this is the same picture. I just
Yeah. And
so as you
so
could
you
see
that
the
little
width,
black area is all it is. So that's
yeah,
probably, like
point
less
0.7,
than
I
a
think,
millimeter. Yeah. So that's probably 0.7 That's got to be in
millimeters.
millimeters.
Yeah.
Yeah.
Yeah. So
So
it's less than a millimeter, right? And
yeah,
I think the other side, oh, I was just going to show a normal, but yeah, I didn't, the other side I think was,
it would have been like, I bet it was at least 2 millimeters,
yeah, right.
and
So
at
you look at the
least.
thickening and just, I have one more picture here of a normal. I mean, I think this might be the other side, the good side, but I'm curious if so this is inspiration and expiration. This might be a
No, the other way
different
around.
patient. Yeah,
Expiration at
expiration and
rest.
inspiration.
Yeah.
My question for you is, I don't know how well you can see where the marker is, the line at the
Yeah.
measurement. Is that where you would measure typically, or how do you
That
decide where to measure?
looks so yeah. So what I do, yep, that looks like it's well measured. The main error I see is people, a couple of things. One, including the white connective tissue, which in the case we just had, if you do that, you get a much thicker measurement than you should be. And yeah, it's not accurate. So I do not include the connective tissue. I just put the caliper directly inside it. And these look
Okay.
well marked. And then sometimes people will do, because of the way, it's kind of on an angle, just because of the anatomy of the diaphragm. So you want to make sure you're perpendicular to the angle of to the
So
direction of the diaphragm. So that one's,
this is,
yeah,
right,
exactly. Rather than if you
rather
were
than
to take
straight
that
down.
part, exactly, because then you get quite a bit longer measurement and it's not as accurate.
Right.
That would be the only, but yeah, they look well marked to me.
And then like, so when you're deciding on, so you can see, I guess my question is also here, you see the diaphragm, you see it over here, and I'm going to play one more last video here. And this is another one, different patient. Sorry, the marker's still on there, but if
That's
you
okay.
know, you see the diaphragm
There.
thicken, and then the lung comes all over here. So, I'm not at the bottom space,
Right.
intercostal space of the extent of the lung. So
Yeah,
what, does it
it
matter where
doesn't
you measure?
it doesn't matter where you measure unless you're going to call it abnormal. So if you find anywhere that's thickening nicely, I think that's fine. It just shows that it's functioning, it's working. What I do say is if you find an area where it's abnormal and you're going to call it abnormal, then make sure you scan around and check a few different areas, because there are some normal people who have just these little areas of eventration in their diaphragm where it doesn't thicken in that spot. So that's my main caveat, is make sure you're not overcalling it by not looking in enough places. And the
Mhm.
other thing would be, I try to measure it in an area where I can safely put a needle in if I want to needle it later. So I don't like to do a space where the lung's coming in at the beginning of a breath. Ideally you find a space where there's no lung coming into the field of view when they take a deep breath.
So
So this space would be pretty
needle,
risky because You put
Yeah,
your needle
that's
in,
a,
you're right in the lung there once they take a breath in.
right,
So typically, if you go down lower, like another intercostal space, one or two lower, you'll be able to find an area where the lung doesn't come in, or
right.
it only comes in with a really big breath in, and then you just don't have them do that while you're needling them. But from the point of view of getting measurements, you can go really anywhere that you find a nice picture. In different people's anatomy, you sometimes have to scan around a bit to find where you can see it best.
Yeah. Do you think this is a normal lung? A
Yeah,
normal
this is
diaphragm?
this is very normal. Yep, you can
Yeah.
see.
This
First
is
of
me,
all,
I think. I'm pretty sure this is mine.
I
So,
would say so. That case that you had that we just presented with the completely atrophic side, I've never seen one that atrophic where you can even find the lung coming in because they're not
mm,
expanding the lung enough. They're not able to flatten that diaphragm and bring the lung down into your area where you're looking.
right.
So that's kind of another tip off. If you see a lung like this, you should be finding a good healthy diaphragm
Yeah.
if they're moving that much air.
And going back to this case, so with this information, would you needle this? Would you try to put a needle into here and
It would depend a little bit on, it would depend a lot on the clinical scenario. First of all, the patient would have to be okay with it. Secondly, it would only if it was going to base some treatment decisions on finding out that information. So what the needle can tell you is, first of all, it can confirm that it's neurogenic, not myopathic, but that's unlikely when it's so unilateral. I'd be
Mhm.
surprised to see the other side looking so good and this side this bad, and it be a myopathic process. From a neurogenic process, if it's neuropathic, you would expect, it'd be nice to get some information about, are there any motor units? Are there any fibrillations left even? Sometimes these become electrically silent because they're just so atrophic. You don't find anything with the needle.
Mhm.
Um, so if I somehow think I really need that information, I might, but a lot of our physicians won't even needle it when it looks like this. Um, because a lot of times it's a matter of if it's Parsonage Turner, which he sounds like he had a pretty good history for that, you want to wait at least, we typically wait at least a year to a year and a half, but actually there is some evidence to suggest that some patients might see some improvement even at 2 to 2.5 years. Like Dr. Klein sees a lot of these patients, and he said he's seen a number that have actually got some recovery that late.
Mm.
So typically the main treatment for this, if you're going to do something surgical, is going to be plication. So
Mhm.
I think trying to hold off on that is not a bad idea until you make sure they're really not going to get any recovery.
Right, right. So,
Um,
okay, so the needle exam might help give you some idea that there's some intact nerve with some motor
right,
units,
right.
but when you see, I guess what I'm hearing is maybe if you have no CMAP, you have no thickening, you have a very small diaphragm, the chance that the needle is going to help you is
Yeah,
probably pretty low in this
I
situation.
would agree with that. And it's going to be a hard needle exam because that's 0.7 millimeters thick. So you literally get the tip of your needle in it, and then if you move at all, you're going to be out of it. So, it's not very high risk because there's no lung coming in anywhere near where you're at. You're just going to go into the liver if you go too deep, and they'll usually tell you because that peritoneum covering the liver is very sensitive. But it's tricky because there's so little. You're mostly going to be in intercostals, and then you're going to get this tiny little ribbon of muscle to get the tip of your needle into.
Right.
So generally you often will see a few fibs. You might see one or two really, you know, complex units. But definitely there's quite a number of these where you don't find anything. So then you've
And,
kind of needled them for
yeah, and
not
I
to
think
add
it's
anything.
also and it could be difficult because you get the intercostal firing too when they're
Hmm.
breathing, and then you're trying to, it's
Yeah, they're
hard.
loud
They're
and
loud, yeah.
they're right next to where, because exactly these patients are often using their intercostals because they're so short of breath. And so it's hard to get them quiet while you're trying to listen for the
Right. So
characteristic diaphragm firing.
right. So then you're not really sure if I hear motor
Right,
units, is
right,
this really intercostals or not? So
right.
yeah. And then the last question is it was you mentioned early on, some other more diffuse neuromuscular disorders like myopathies. That's rare to cause severe respiratory problems with myopathies. But from an ultrasound and diaphragm standpoint, if someone had, say, a severe myopathy affecting respiratory muscles, you wouldn't typically have unilateral significant differences. Is that
No,
correct?
we actually pulled that data from our lab from over the few years that we'd done diaphragm ultrasound, and we found a small series of a myopathy, diaphragm myopathy, and I don't know if it was even 18 patients. And what we found in that was there were a few that had some more unilateral involvement, surprisingly, but there were quite a few that had normal thickness at rest, but then they had abnormal thickening ratios, so they weren't contracting well. And there were a handful of cases that only had the abnormal thickening ratio on one side, I think. I
Hmm.
presume those were kind of more mild myopathies. They had EMG. These were all ones that had EMG evidence of myopathy on needle exam.
Hmm.
So
Okay.
we've got a little bit of data on it, not a lot, but myopathies classically do preserve muscle thickness on ultrasound, and then but the muscle echogenicity will change, and then of course if it's not functioning well, the contractility will change. So that's what
Hmm.
we're looking at with. We don't really have any data on echogenicity in the diaphragm. I just think it's tricky unless you have
Hmm.
a big enough, thick enough diaphragm to get a nice region of interest to measure the grayscale. I go much more on the function, which I base on the thickening.
Right. Right. Okay. And so if things were fairly symmetric and there was a suspicion of myopathy in which you might still get CMAPs, you might not have
Right.
though that would be a situation that you would more
Definitely,
likely needle
definitely
the
needle would
muscle.
be helpful there. Yeah,
Yeah.
I
Okay.
think so. And it would tell you how severe it was. You'd see fibs and you'd get an idea of the motor units. I mean, diaphragm motor units are on the smaller side, but when you get myopathies, they're really pretty tiny usually. So
Right. Good. So if for any listener who's not as comfortable or is learning ultrasound and wants to learn to do this with the diaphragm, do you have any advice for them or suggestions on how to learn how to do this?
So, I mean, the main thing with learning ultrasound is getting access to a machine. Once you have access to a machine, it's quite easy to learn because we have ourselves to look at. And so, diaphragm, I definitely recommend starting out on normal people and non-obese people. And it's pretty easy to find in them. And then you can see the thickening. And the more normals you do, the easier it is to start doing the abnormals. And again, as I mentioned earlier, if you are doing a patient that you're considering one side, I would always start on the normal side first. My usual
Mhm.
rule of thumb is I start on the right side because the diaphragm's easier to see on the right. The liver just gives a really nice acoustic window, and this on the left side you have spleen, but you sometimes have stomach or a gas bubble in the stomach or something. So if you can start on the right, great. But if you know that the right side's abnormal, I usually would start on the left. Take a
Mhm.
look, see what it looks like, and then you that gives you your landmarks, your depth, where you should expect to see the diaphragm, and that kind of helps you figure it out when it is abnormal.
Yeah. So I imagine you've scanned your own diaphragm many times. Does yours look better than mine that I showed you?
Uh, well, I
We'll have to compare diaphragm
pretty
scans one day.
pretty sure it does, Devon.
Yeah,
Mine like doubles or triples. What is
yeah,
yours? You'd have to show me yours again. Yours
I
look
would.
pretty good.
Yeah, it's
Yours look
probably the
pretty good.
golf. You play more golf, and I'm sure that has an effect on the diaphragm. So that's got to be it.
I think it might be more my Peloton.
Yeah. Well, I guess yeah, the point is I better exercise more to try to keep up with you. So. Well, this is great. This is really, valuable information. I think this is an interesting area, and not as many people do phrenic nerve assessment. It's a complicated area. So your insight and experience that you've shared here, I think, is really valuable and will be valuable for the listeners. And I really appreciate it.
Yeah, you're welcome. It was nice chatting today, Devon. Have a good
Yes,
day.
and I hope you have a great rest of the day and not too many complicated surgeries.
Yeah, me too. Thanks.
Goodbye. I hope you've enjoyed this episode of Lessons from the Lab. I hope you found that it was valuable and educational in your practice, whether you perform neuromuscular ultrasound or not, or whether you assess diaphragm function in the EMG laboratory or not. I certainly got some very practical information from Andrea. It's interesting having her look at some of the ultrasounds that I've performed, giving some of those tips of how you identify the diaphragm. And I think as we saw, it's not always easy to identify the structures that are truly the diaphragm and distinguishing that from the intercostal muscles. I think it's also useful to understand how do we measure the diaphragm thickening to in, to minimize pitfalls in measurements and ensure accuracy of the measurements and interpretation of the findings. And I think it's also important to understand the utility of performing the nerve conduction studies and neuromuscular ultrasound in assessment of these complex patients. So hopefully you found this useful. For those of you who are learning or are planning to learn neuromuscular ultrasound, as Dr. Boon said, practice, get a machine, practice on yourself. It's easy to test the diaphragm, doesn't hurt. It's kind of neat to see your diaphragm move. So I would encourage you to do that when you're bored and have nothing else to do. Bye-bye.